Hello, this is Dr. James Camp of Lee College in Baytown, Texas, and this is the physiology of the ventilation stage of respiration. We're going to talk about pulmonary ventilation, the inspiration and exhalation, the muscles used, the pressures that are involved, some of the things that produce air movement into and out of your body. We're going to talk about the measurement of proper ventilation, and we're going to talk about some of the things that happen in your brain that control ventilation. Okay, so you have this cycle that happens in your lungs where you start with intrapulmonary pressure equal to P atmosphere. Okay, at see if I can draw that a little bit better. PIP, yeah. Intrapulmonary pressure equals P atmosphere. No air is moving because there is no pressure difference. The diaphragm moves down, the rib cage moves out. You increase the volume of your lungs, and so now PIP decreases. P atmosphere is steady at about 760 millimeters of mercury if you're at sea level on a mild day, okay? But PIP is now less than that. So naturally, if P atmosphere is greater than P intrapulmonary, we're going to see a flow of air this way from high to low. So that is in fact what we see. Air moves into the lungs until P atmosphere once again equals, until P intrapulmonary once again equals P atmosphere. Okay. Then the diaphragm relaxes, the rib cage falls back to its normal size. Your lungs get smaller. At this point, P intrapulmonary rises. And so if P intrapulmonary is greater than P atmosphere, we're going to see a flow of air in that direction from intrapulmonary to atmospheric. So once again, this time we see a flow of air out that way. So what produces these volume and pressure differences? Well, the lungs basically occupy most of your thoracic cavity. So if we imagine that the thoracic cavity can increase in size in one of three ways. It can get taller, it can get wider, it can get deeper. We have three different things that we can do to increase the size of your lungs. One is to make the thoracic cavity taller, and the primary way we have for that is the diaphragm muscle. Okay, the diaphragm muscle is normally a dome shape. When it contracts, it flattens out a bit, and that pulls your lungs down, expands your lung volume in a downward direction. We also have the ribs. The ribs are anchored at the anterior side to the sternum and the posterior side to the vertebrae, but laterally they are completely free to move. Normally your ribs hang down a little bit, but we can pull up on them to expand them laterally here, or we can pull down on them to pull them in laterally, to depress them and narrow them laterally. Okay, so that can change the width of the thoracic cavity. And then finally, the sternum itself can be pulled up and out or down and in, and so we can both elevate and expand the top of the thoracic cavity or depress it and compress it. So that leads to a question of what breathing muscles do we have? The diaphragm compresses the abdomen and expands the thorax. Okay. Okay. My video stopped recording at some point, but you have all the answers here now, so let's move on. Okay, so sometimes we want to know what's going on inside a patient's lungs. Often we want to know this because the patient is complaining of being, quote, short of breath in some way. And the way we do that is spirometry, from the Greek spiros, meaning breath, measurement of breath. There are several different kinds of devices out there, from wet spirometers that are fairly cheap, even in some cases disposable devices, to a computerized spirometer like the one you see here, where the patient blows into this tube. It goes through this filter, and as it passes through a flexible membrane here, the computer is able to measure how much air has passed out of the person's lungs, and as they're breathing in, it travels in the opposite direction. So the computer is able to measure how much they have breathed out or breathed in, and the result might be a graph like this. The idea here is that this graph shows you the total volume inside the person's lungs at a given time. So as you inhale, that volume goes up, and as you exhale, that volume goes down. Now this first bit of breathing here, this is your quiet, normal breathing. And the amount of air that moves in and out of your lungs is called your tidal volume. Not sure where that comes from. I guess it looks sort of like waves of the tide. But that's the terminology we're stuck with. If you choose to take a deeper breath in, you can add to this your inspiratory reserve volume. And if you start at the end of a normal breath and breathe in as much air as you possibly can, you get your inspiratory capacity. Note that we have volumes, which are the individual bars on this chart, and we have capacities, which are what you get when you add up one or more volumes. Note also that there's a residual volume down here that we can't touch. That's the amount of air left in your lungs when you have breathed out all the air you're capable of breathing out. You never completely deflate your lungs. If you did, it would be disastrous for you, because you might not be able to reinflate them again. But the point is, you don't ever completely deflate your lungs. So there's about 1 liter of air left in your lungs when you're finished with a deep breath out, and that is your residual volume. And there's no way to measure that using a spirometer, because we can't measure the air. We can only measure the air that moves in and out of your lungs. Well, if you've taken this deep breath in and you decide to blow all the air in your lungs out that you possibly can, that gets you your vital capacity. If in addition you're trying to blow it out as fast as possible, that gets called a forced vital capacity, or FVC. Okay, and the other number that we cannot measure is your total lung capacity, because that includes the residual volume plus the vital capacity. These are some normal volumes and capacities for a normal patient. Whatever normal means in this case, I suppose sort of averages across the population. Quiet breathing, interestingly enough, is not affected by whether you're male or female, just by how much air your body needs, I suppose, at rest. But all of the other capacities are significantly larger for males, about half again as large for males as they are for females, because males have larger chests, sort of a broader, deeper chest, and are able to, if they push themselves, breathe more air in and more air out. Now that's on average. I have in my classes, when we've done these experiments, I've had women outbreathe men. So it's really, a lot of these things vary by individual as well as by gender. Okay. So you may wonder, okay, how do you get from something like a 500 milliliter breath, half a liter moving in and out of your lungs, to a vital capacity of several liters? Something has got to trigger a change in your breathing apparatus. And those somethings happen to be deep in your brain stem. There are two sets of respiratory centers in the medulla oblongata, and so they are referred to as medullary respiratory centers. And there are two sets that are up higher in your pons, and so they're called pontine respiratory centers. The medullary centers are called the rhythmicity area because they set your basic breathing rhythm. Your ventral respiratory group, also known as your inspiratory area, for about 2 seconds will stimulate your quiet inspiration muscles. Then for about 3 seconds, it will allow those muscles to relax. Now again, that's on a person who has an average normal breathing rate of 5 seconds per breath or 12 breaths per minute. A lot of us breathe at different rates than that perfect 12 breaths per minute, so your mileage on this may vary. The dorsal respiratory group integrates input from the peripheral sensors that we'll talk about on the next slide and modifies the rhythm of the inspiratory area. So it's not for taking a deep breath, it's not for holding your breath, it's for still this very deep unconscious modification of your breathing rate, such that, for example, if you're mildly exercising or something, the dorsal respiratory group may increase your breathing rate a little bit. The pontine respiratory centers are for major modifications to the breathing rhythms. The pneumotaxic area, if it is stimulated, it will inhibit the inspiratory area to stop the lungs from overfilling. Okay, it is possible to fill your lungs so much that you've stretched all those all those fragile membranes, and the lungs start feeling overstretched. And if stretch sensors in the lungs stimulate the pneumotaxic area, it will shorten inhalation. If it feels like you've been taking too many deep breaths, it will make your breathing more rapid. The apneustic area is the opposite. It stimulates your inspiratory area to prolong and deepen an inhalation. This is what allows you to take a deep breath. Okay. To hold your breath underwater if you're swimming. It's what allows you to to take a deep breath prior to blowing on that musical instrument we talked about earlier, or blowing up a balloon or something like that. Apneustic means no breathing. Okay, it stimulates you to deepen your inhalation and hold your breath. Okay, so how do these various brain centers make their decisions? The most important inputs that come in are from chemoreceptors. There are central chemoreceptors built into your central nervous system, built into your brain, and there are peripheral nervous chemoreceptors in your aortic arch and in your carotid body. Remember that carotid sinus that we talked about a couple of units ago in studying the blood vessels? Well, those produce a report for the brain on how much oxygen is in your blood, how much CO2 is in your blood, and what your blood pH is. Interestingly enough, oxygen is the least important of those inputs. Okay, your body seems to know that you're going to suffer from too much CO2 before you would actually suffer from not enough oxygen. And that's true. You would actually, if you die from lack of fresh air in the room, it's the buildup of CO2, not the depletion of oxygen, that will kill you. Receptors in your muscles and joints, I want to point out here, and you can do this experiment. If you measure your breathing rate, the moment you start exercising, the moment you start moving your arms and legs, to jog in place or something, your breathing rate increases. It doesn't wait for you to find out that you've got a buildup of CO2 or a depletion of oxygen. It immediately starts increasing. And that's because there are direct inputs from your muscle receptors to the brainstem. There are also stretch receptors in the lungs and irritant receptors in the lungs that tell you to stimulate your pneumotaxic center, that tell you to breathe out. The lungs are overstretched, or you've breathed in a little bit of acrid smoke from a bad fire or something. You're going to try to breathe out. You're going to try to expel those irritants. Another interesting one is the hypothalamus, which we remember from A&P1, integrates pain and stress signals from all over your body. If you're stressed out, what happens? You breathe more rapidly. Okay, we're not sure exactly why your body has that reflex built in, but it does, and so stress hyperventilation is a thing, and it's done by the hypothalamus. And then finally, of course, your conscious brain, your motor centers up here in the frontal cortex are going to have the last, they're not going to have the last say on breathing, because the pontine, the pneumotaxic center can override everything else and cause you to start breathing again, even if you're trying to hold your breath for a long time. But the conscious brain does have a say in what your brain does. Okay. Finally, getting back to pulmonary function testing, there's a question of why do we care? And the answer there is that there are two very different causes of the phenomenon we experience as being short of breath. One is called restrictive lung disease, and that's where your lungs are restricted from expanding to their full volume. Imagine having a broken rib and you just can't expand your rib cage enough to breathe in. That would be a restrictive lung disease. That one's fairly easy to diagnose. You've got a broken rib, okay? But there are other things that cause your lungs to not be able to expand. Tuberculosis and pneumonia and pulmonary fibrosis and asbestosis. What all of those have in common is that something that shouldn't be in your lungs is, whether it's tuberculin, toxin, or pneumococcal bacteria, or fibers, or asbestos. Something in there is irritating your lungs, and they're inflamed, and they're not expanding like they should be. It reduces the compliance of your lungs, keeps them from expanding outwards. Another interesting one here is obesity. Okay, obesity, you carry your extra body fat most commonly in your abdomen. I certainly do. So as you put on more pounds in your abdomen, it's more difficult for your diaphragm to push down on the abdomen and expand your lungs. And so people who are very obese find it harder to breathe, and that's a restrictive lung disease. The more common of the two is obstructive lung disease. This is where you can breathe in fine as long as you're using all those breathing muscles we've talked about, but breathing out is difficult. Airflow out of the lungs is obstructed in some way, usually by narrowed airways, but it can also be damage to the elastic tissue of the lungs that makes them slow to expel the air. The most common is probably asthma, where for some reason that usually is not diagnosable, the airways of the deep lungs constrict at inappropriate times, and it makes it hard to breathe out. And so carbon dioxide gets trapped in the deep spaces of your lungs, and you feel short of breath, even though you're actually moving enough air into your lung every time you breathe. You're not moving the carbon dioxide out of your lungs. As I say asthma is difficult to diagnose because, or it's difficult to find a cause for, because it's not obviously caused by an infection. It's not obviously caused by damage to your lungs. It seems to be a conglomeration of allergies plus exercise, or exercise plus cold air, or cold air plus allergies, or most people, their asthma is triggered by a complex of factors that is not as simple as just saying, well, there's one thing that causes asthma. COPDs are very commonly experienced by people who have been smokers, such as emphysema, which is a breakdown of the elastic fibers in the lungs, and a replacement of that with scar tissue. Commonly experienced by smokers. I think we're starting to see some of it with vaping, though, as well. Chronic bronchitis may be brought on by smoking, may be brought on by vaping, may be brought on by just literally getting bronchitis and it never going away. Okay, there are a lot of things that could cause that. And then there's a disease called cystic fibrosis, which is actually quite misnamed. It has nothing to do with fibers in your lungs. It has everything to do with a buildup of mucus in your lungs. People with cystic fibrosis have a defective sodium transporter, actually, that keeps them from getting the right thickness of water and mucus in their lungs, and so the mucus builds up until it's so thick that it's has the same effect as asthma. It keeps you from breathing out effectively. So how can we tell which of these two diseases you have? You need a different set of spirometry measurements. Forced vital capacity is the vital capacity measured when the patient tries very hard to breathe rapidly. Okay, so you tell them to take a deep breath, but then you tell them to breathe out as hard and fast as they can. And then you look at what happens in the first second of this curve versus the rest of the curve. And if we look at that differently, if I take this amount, which is about 2 liters, and I compare it to this amount, okay, this patient breathed out 3 liters in the first second and 4 liters total. So the FEV1 is 3/4 or 75% of their forced vital capacity. That is normal. 70 to 80% is normal. Obviously, this requires looking at your spirometry curve differently so that you can look at times rather than looking at liters versus, well, we've been looking at time anyway, but it requires you to look at the time. Total lung capacity is the important measurement for restrictive lung diseases. We want to know if the patient can increase their lung size as much as they need to breathe. But if you've been paying attention, you'll say, wait, I just told you we can't measure TLC or residual volume. Well, there are ways. You can have a patient breathe in an inert gas like helium, and then it mixes with the air that's already in their lungs, and then they breathe it back out, and there's a fairly simple formula that you can use to determine how much their lung capacity was, how much air was in their lungs to begin with, based on how much of the helium got diluted. Okay. So, in summary, if we want to know that you have an obstructive pulmonary disease like asthma, we'll see that the FVC is normal to slightly low because you're having trouble breathing, but we'll also see that the FEV1 is often much less than 70% of FVC. Even as low as 60% is cause for concern, but I've had some patients in my classes who have uncorrected asthma, they're not currently on an inhaler, whose FEV1 was down as low as 30%. We'd also see a reduced peak flow, and that's another measurement where you can, often done with a little thing that you blow into, and it has a ball that floats up, and the higher the ball gets, the higher your peak flow rate is. That's another quick assessment for asthma. Restrictive pulmonary diseases, we want to measure a restriction in your lungs' ability to expand. So we would see a decreased forced vital capacity. We'd actually see FEV1 being a slightly high percent of FVC because you don't have much trouble breathing out, you're having trouble breathing in. But the definitive criterion is a TLC that's less than 80% of the normal range for your age and gender. Okay, age and sex, I should say. All right, so that's it on pulmonary physiology. It wraps up our discussion of the pulmonary system. I hope you've learned something. I hope you've enjoyed the presentation. If you do, give me a like, leave me a comment, and as always, keep learning and keep studying, and we'll be back next time with the digestive system.